Hello, my name is Maura Cotter. I'd like to thank the organisers for asking me to speak at this very interesting meeting today. I'll be talking about our current diagnostic pathway in St Vincent's University Hospital and some of the challenges facing histopathologists in relation to cancer of unknown primary. The majority of patients with cancer today present with a clearly defined primary malignancy that manifests with typical local or metastatic symptoms. However, 10 to 15% of patients present with metastatic disease from the outset, rather than with a primary tumour. In about 2/3 of these, the primary site is identified during clinical investigation or over time. However, in the remaining third of cases, the primary site is never found. Cancer of unknown primary origin, or CUP, is therefore a common and challenging clinical problem. Pathologists are important contributors to the multidisciplinary effort to identify the primary tumour origin in these patients. Our aim is to broadly classify and subtype the cancer, and where possible, to confirm the likely primary site, as this information best predicts patient outcome and guides treatment. Diagnostic evaluation in these cases generally involves a complex clinical assessment to attempt to pinpoint the tumour origin, and biopsies for pathology may be taken at any stage in the diagnostic process. Good communication between all clinicians involved is key. Knowledge of a past history of primary malignancy is especially relevant to the pathologist, as direct morphologic comparison with prior histology slides can easily be performed and may result in sparing of precious tissue. Other pertinent information, including patient symptoms, serum tumour marker status, endoscopy results, and distribution of disease on imaging, are very helpful and are often incorporated in the pathologist's final diagnostic report. Tissue samples may be submitted from any anatomic site in a case of suspected CUP, including endoscopic biopsies, small CT or ultrasound-guided biopsies, and even smaller cytology samples where individual cells are examined. The most common sites of metastasis in CUP, and thus of biopsy, are in solid organs. Therefore, biopsies of the liver and lung are most frequently encountered in our lab. Other common sites of metastatic disease include lymph nodes, bone, peritoneum, adrenal glands, and skin biopsies. One of the main challenges pathologists face today is that samples are becoming less and less invasive, resulting in smaller and smaller specimens. At the same time, advances in therapeutics have led to increased numbers and complexity of tests required from the same piece of tissue, including biomarkers for risk, diagnosis, prognosis, prediction, and response, some examples of which are listed here. Therefore, the likelihood of a CUP should be communicated as soon as possible so that appropriate measures can be taken prior to any tissue processing. Sample receipt and handling follow specific standard operating procedures, or SOPs. In a case of suspected CUP, our approach is to embed the entire biopsy in order to not miss the identification of any areas of better differentiation at a later stage. If there are multiple fragments of tissue, these are embedded in separate cassettes to maximize tissue availability. Biopsies then go through a series of processing steps before coming out as a wax block, referred to as formalin-fixed paraffin-embedded tissue, or FFPE. Sections are then cut and stained by immunohistochemistry or sent separately for DNA or RNA extraction for molecular analysis. The histology tissue sample is invaluable and must be utilised with caution to ensure the maximum diagnostic yield and to avoid the need for the patient to undergo a second biopsy. So, in our laboratory, upfront serial spare sections are retained for the use of a select immunopanel while conserving the remainder of the tissue for future molecular studies. Antibody cocktails are used where possible, where 2 or more antibodies are placed on the same slide rather than one in order to conserve tissue. If malignancy is identified on biopsy, the amount of tumour tissue present and the amount of necrosis must be confirmed in order to determine adequacy for further studies. Percentage tumour within the tissue sample is particularly relevant if molecular studies are to be carried out later. If the percentage of viable tumour is too small, it will be difficult to find a somatic mutation, as it will be drowned out by the DNA of the background non-neoplastic cells. Next, careful morphological analysis is performed on H&E, which can rule out a non-carcinoma tumour subtype like melanoma, lymphoma, and sarcoma, with or without the aid of immunohistochemistry. Immunohistochemistry, or IHC, is performed routinely in pathology laboratories around the world to determine the expression and localization of proteins or other antigens within a tissue specimen using specific antibodies. It is fundamental to cancer classification in pathology. If the tumor is broadly classified as a carcinoma, it can be subtyped as squamous or urothelial, neuroendocrine, solid organ, or adenocarcinoma using various markers, including those listed. If it is an adenocarcinoma, the likely site of origin can next be suggested using other markers in a panel, such as proposed in the most recent NICE guidelines, which include CK7, CK20, and TTF1, EOR or PR if female, or PSA if male. The figures in each square here represent the percentage positivity in each tumor type. So as you can see, it is not black and white. No IHC test is 100% specific, so antibodies need to be used in panels as the result of a single immunohistochemical stain can be misleading. And final diagnosis should never depend on immunohistochemistry alone. It must be made in the correct clinico-pathological context. Some diagnostic difficulties for non-pathologists to be aware of include that the more poorly differentiated a tumor is, the less likely it is to express tissue antigens, i.e. the markers used on the tissue may all be negative. Also important is to recognize that tumors are heterogeneous, and therefore a single small tumor biopsy may not actually be representative of the entire tumor. There is no current international consensus on the optimal pathological approach in these cases. However, current European and US guidelines recommend a stepwise histopathological approach, as I have just illustrated. In terms of the staining itself, difficulties exist when no specific or a few non-specific immune markers are positive, when the staining is hard to interpret due to insufficient tissue, necrosis, or poor quality of staining, or when the results conflict with the morphology or with the clinical scenario. A recent interesting example from our laboratory is one of a metastatic colorectal adenocarcinoma not staining with the typical CK20 positive, CK7 negative profile, but was consistent with a metastatic colorectal carcinoma as the primary tumor stained in the same way. So it's always a good idea to look at prior histology and compare the morphology and staining patterns with any new patient samples. In the second example, we see an epithelioid tumor with strong cytokeratin expression, making metastatic carcinoma a strong diagnostic consideration. Vasoformative foci were seen on H&E, however, and subsequent ERG positivity was noted. ERG is a transcription factor expressed in endothelial cells, confirming this then to be a rare metastatic epithelioid angiosarcoma, keratin positivity being a diagnostic pitfall if unaware of this particular staining profile. This is really a rapidly evolving field, and pathologists are challenged with keeping up to date with new and emerging immunomarkers all of the time. There is a movement away from traditional cancer classification by tissue and organ type alone, with more cancers now also being subclassified by their molecular characteristics. So in cases of suspected CUP, it's good practice to conserve some material for potential molecular analysis after IHC. There are a variety of sample types that can be analysed, including cell culture, body fluids, and both fresh and fixed tissue, each having various advantages and disadvantages that must be considered. Many different types of molecular techniques are available, ranging from simple, fast assays that interrogate a single area to large, complex assays that can sequence the entire genome. As molecular pathology is a rapidly changing field, what was cutting edge 5 years ago is now considered outdated. So again, it's a challenge for the histopathologist to remain up to date with frequent advances in technology. Some suggested indications for testing include the following. Any patient without IHC patterns diagnostic of a single primary site or tissue of origin, small biopsy specimens insufficient for IHC evaluation, a history of previous cancer or cancers, and the IHC is inconclusive, an atypical presentation or clinical presentation that does not match pathologic characterization, or where biomarker analysis is to be performed as part of personalized therapy or for potential diagnosis. The number of druggable tumor-specific molecular alterations has grown substantially in the past decade, with some targets identified by IHC, some by FISH, and some by PCR-based methodologies. Mutational testing is performed in our laboratory using material extracted from paraffin-embedded tumor tissue. At least 10 to 15% of tumour cells are required for adequacy, with higher amounts needed to assess for fusions, amplifications, losses, gains, etc. Single gene testing by PCR is currently available in-house and includes testing for KRAS, EGFR, BRAF and NRAS. We plan to introduce next generation sequencing or NGS this year, which will allow the simultaneous detection of multiple genes from the one patient sample, thereby conserving precious tissue. Targeted gene panels are generally preferable in the clinical setting as they cover hotspot regions with known actionable mutations. As well as identifying drug targets, molecular profiling can also be used as a diagnostic tool to suggest site of origin in patients with CUP, as shown in a recent paper from Memorial Sloan Kettering Cancer Center. For example, if a BRAF mutation was identified in a sample, metastatic melanoma would be on top of the list, or identification of an EGFR mutation, for example, might suggest a lung primary. Immunotherapy is also emerging in several cancer types, with promising response rates seen in patients with metastatic disease. Therefore, it would be reasonable to expect that a subset of patients with CUP may also respond to immunotherapy. Markers of responsiveness to immunotherapy currently performed in our laboratory include mismatch repair IHC and PD-L1 IHC. In terms of mismatch repair status, it should be noted that 4 separate sections of tissue are required from the biopsy for 4 different antibodies: MLH1, MSH2, MSH6, and PMS2. If loss of protein expression is seen, tissue is then sent for further BRAF or hypermethylation testing, depending on tumour type. PD-L1 IHC is carried out on samples with at least 100 viable tumour cells present on H&E. This test requires 2 separate sections of tissue, one for the stain and one for the negative control. Unfortunately, as part of the clinical development of the currently improved PD-L1 inhibitors, separate assays were developed in parallel for each as companion biomarkers. Therefore, there is considerable variability in PD-L1 testing, with each inhibitor having its own primary antibody clone for IHC, its own detection reagents, staining platform, and cutoffs for positivity. This is therefore a difficult marker for the pathologist to score and requires specific training and experience. In summary, the diagnosis of CUP remains challenging and requires a multidisciplinary team effort to identify the primary site. The roles of the pathologist in the diagnostic pathway include the control of pre-analytical conditions, the assessment of sample adequacy, the diagnosis of cancer, and the evaluation of prognostic and predictive markers. Sparing of tissue for molecular analysis is critical, as targetable mutations or indication of site of origin may be identified in some cases. An integrated diagnostic report is ideal, with discussion at a forum such as a molecular tumour board. This approach will hopefully lead to improved clinical outcomes for patients with CUP and may help to enrol more of our Irish patients in international cancer clinical trials. So with that, I will close. Thank you for listening, and I hope you all enjoy the rest of the meeting.